Hello, my name is Lee Breakwell. I'm a spinal surgeon in Sheffield, and in this presentation we're going to talk about how to assess and what to look for with regards to red flags. All the other talks we've alluded to red flags because they're so fundamentally important to the assessment in a safe manner of a patient with back pain and neurological symptoms. We just thought we'd just do a little highlighted talk on specific red flags. If you look in the literature, there are over 70 red flags that denote a higher risk of pathology in a patient with back pain. How are you supposed to know what's important? The one to take away here, in my world, in terms of serious risk, is the most useful red flag is a past history of cancer. Has that patient had cancer before? Have they had a strong history of it, or even something 10 years ago that they believe is cured? Often that's the case. The sad reality is a past history of cancer significantly increases your risk of having metastasis of the spine, which could be disastrous. So in a patient with back pain that isn't the typical mechanical, routine, bog standard back pain, just think, is there a red flag? The number one best-selling red flag being past history of cancer. On top of that, past history of infection. Spinal infection is very common, sadly, and can be disastrous and is all too often delayed diagnosis. So again, past history of infection, whether that be generalized sepsis or specific infection of an ingrown toenail or in a knee joint or recent chest infection, UTI. Somebody who presents with thoracic back pain in particular, progressive, indolent, unremitting, constant nature back pain, who has a past history of infection, just think, is this a red flag version? Is this infection of the spine? Let me make the diagnosis with an MRI scan, easy to do, saves a whole lot of grief for the patient and serious risk. So in general terms, red flags are features in the history, particularly, that make you concerned that the patient has serious spinal pathology. So number one is tumour, number two is infection. Once you've gone past that, you've got the whole host of the others, which are much softer signs, and really you need to add 2, 3, 4 or even 5 of them to make you concerned of a diagnosis of a serious spinal pathology. The examples in the textbooks are varied, and every book you read will be slightly different. Age is the common one. So a patient in a textbook below 16 with back pain is classed as a red flag. That's nonsense. I see patients every week with mechanical back pain in the children's hospital. They don't have serious spinal pathology. But you do need to suspect a child perhaps below the age of 12 with back pain, likely to be nothing, but there's a much higher risk that is more serious. So the second peak of age to worry about with red flags is over the age of 50. The reason for that is myeloma kicks in with a significant incidence at the age of 55. And all too often a patient will present with new onset of back pain at that age. Just think, could this be myeloma? The second common cause of pain at that age is of course metastasis. So primary spinal tumours are really rare. They do exist, but much likelier that this is a metastasis. So there are the tumours that commonly metastasize to bone, breast, lung, kidney, prostate, and these will commonly affect the spine. And all too often we see patients with thoracic pain, past history of cancer, they have a metastasis. So looking for a sudden change in pain above the age of 50. Of course, you hopefully have picked up that there's a past history of cancer, but there may be a cancer of unknown primary, first presentation, and that needs to be flagged up because of their age. Then there are the constitutional symptoms, so fever, weight loss, change in appetite, general malaise, much softer signs. Thoracic back pain is a relative red flag in its own right, but it's not a very sensitive one. So there's a long list of things that you can read in a book that aren't necessarily very helpful. So to reiterate, red flags are features in the history or on examination that make you nervous of serious or sinister spinal pathology. Number one is a past history of cancer. Number two is a past history or a recent infection or risk of infection, such as immunosuppression. And then there are the softer signs. You mustn't forget the neurological findings. So we've talked about the history. When you look at examination, lots of patients will have a bit of tingling, a bit of numbness, even weakness of their big toe with radicular leg pain. That's not serious. It might worry the patient, but that's not a sign of serious spinal pathology. A foot drop is a commonly distressing feature of radicular leg pain. With L5 or L4 affected, you might get a weakness of the ankle. To me, that's not a red flag, but to the patient it is. So that's a relative indication for urgent referral, but it's not an emergency. Neurology rarely spreads due to radicular pain. If it's cord compression, that's different. So a red flag in its own right is a risk of cord requirement syndrome or cord compression. So cord compression will have thoracic back pain typically, numbness, tingling below that level, weakness of the legs, ataxia, unsteadiness, high reflexes, upgoing planters, the usual findings of cord compression. You need to think and look for that. Cord recliner syndrome is rare, thankfully, but it's a devastating condition and it creeps up on patients. So patients who have back pain, bilateral leg pain, saddle anaesthesia, saddle paresthesia, reduced anal tone, alterations of bowel and bladder habit. Again, that's a red flag, needs an urgent or even an emergent referral depending on the findings. So in summary, red flags are part of the history in the examination. You have to suspect them. The skill that you've developed as primary care clinicians is your spider sense. Something's just not right here. This isn't day-to-day mechanical back pain. The pain is different, the way they describe it is different, something about the history is different. Please, please, please don't forget tumours, don't forget infection, and look for the neurological findings with the broad brush examination technique, which we cover in our examination presentation as to how to assess for broad neurology. Is a simple way to screen the patients for significant neurology and, if necessary, refer the patient.